I'm here at the Health Services Cost Review Commission, and also Russ Montgomery with DHMH is also here with us today. We wanted to have a brief webinar to review the data that we've sent out to be of assistance to you while you're developing your regional partnerships for health transformation. I wanted to let you know that we're recording this session so that others that aren't able to attend today can listen to it after the fact. We sent out an email, but we also have the data that we sent out in the email and the data that we provided on a website that is provided here in this PowerPoint presentation, which will be posted to the website after the webinar today, so that you can find the link again if you don't already have it in your email. Just to briefly highlight what has been sent out and to talk about how you might use it, we sent out an Excel worksheet, and that worksheet contains information on high utilizers of hospital care and on chronic conditions that we found in the hospital inpatient and outpatient discharge data that was submitted to the Health Services Cost Review Commission by hospitals for calendar year 2012. In that workbook, we've provided data at the county level. The second set of resources are on the web, and they're in a Tableau table a graphic table that you can look at. Those are extracts from the CMS chronic condition warehouse and their chronic condition reports by county. Those reports are generated from a broader set of claims than just hospital claims, so they should be identifying some additional chronic conditions. And so they would be having both hospital claims as well as all of the claims from the community providers like physicians and skilled nursing facilities, etc. And so those two resources are focused on the chronic conditions and the high-use patients. The third set of resources are from the HSCRC inpatient discharge data, and those resources are showing what services those high-utilizing patients are using. So if we're looking at the top 10 DRGs for the high-utilizing patients in each county, what are those DRGs? And if we're trying to focus on reducing avoidable conditions, this will give you a view into what the hospitalizations were for those high-utilizing patients. And what we want to do with this information in terms of your planning process, we've talked about in the RFP several needs. One is focusing on developing care coordination approaches for high-needs patients. And so if you start looking through the data, you'll see that there are approximately 40,000 patients statewide that we categorized as high-needs patients, and that is based on patients who had 3 or more inpatient visits. And when we start looking at the Medicare population, because we want to start out by focusing on the Medicare population, it's about 3 to 5% of the Medicare beneficiaries in the state. And we think these patients would be ideal for intense management approaches. They comprise about 1/3 of hospital charges for inpatient and emergency room. And the average charge for these patients at the hospitals in Maryland for this data period was about $74,000 per patient, and on average they had just over 4 inpatient visits. At the same time as we're focusing on the high needs patients, we're also trying to focus on how to support the community-based providers and the primary care providers as they address the chronically ill patients, particularly with the introduction of the new Medicare chronic care management fee that was effective January 1. So to kind of take a look at what might be an ideal mix of patients for the chronically ill, if we think of people with four or more chronic conditions as really needing some extra support from the primary care practices, 1/3 of the Medicare patients have 4 or more chronic conditions. That's about 280,000 people in the state, and those 280,000 people make up about 75% of total Medicare costs. And so that's not just hospital costs, but all Medicare costs. So these are, in looking at the chronic conditions and looking at the high needs patients, we're trying to focus some data, bringing some data to you to understand if you were trying to develop care coordination plans for high need patients, what kind of conditions would they have? Or if you're trying to address helping the community-based providers bring up the Medicare chronic care management fee program, what is it that we would be trying to address in that venue? And now we're going to take a quick tour through the resources that we provided to you, and then at the completion of that, we'll open it up for questions.
Thank you, Donna. This is Allison Schuster, and I'm going to quickly walk us through what we have posted on our website. The web link that is provided will take you to this page, and as you can see, there's the 4 different types of supporting data that we provided. This first link here will be to that Excel workbook, so you can click that and download it. When you download it, you can open it up. There is a, and I apologize, I made this smaller, but want to make sure you can see it. The first page just provides what's in this workbook. So there are 3 tabs down here that have data for people by county for the whole state. And then towards the end, there is actually a separate tab in addition for each individual county. And I'll just quickly walk through each of these. So this first sheet is the all-patient chronic condition report. And this displays the number of unique patients that had any encounter with a Maryland hospital in 2012 with specific chronic conditions by county. So, for example, this first column B here, we have Allegheny County, and there were 22,005 unique patients that were seen with one of the 16 chronic conditions listed. And these chronic conditions are flags that are based on the diagnoses on hospital claims, all diagnoses, and they're rolled up to diagnostic categories using the clinical classification software that's maintained by the Agency for Healthcare Research and Quality. For each chronic condition, it is only assigned once to a patient, but a patient may have more than one chronic condition. So they may have asthma as well as cardiac arrhythmias. So again, what this shows you, and I'll use Allegheny as the example, is that there are 555 asthmatics that were seen in the county in 2012 in the hospital, and that represents 3% of the people with chronic conditions in Allegheny County. You'll note on here that there are cell sizes, or there are cells with missing numbers. Those are blanks due to the small cell size restrictions that we have, which in this case is less than 11 discharges or patients. So the second tab, this presents similar data, but it is for the high utilizers, and that is defined here as patients that had 3 or more inpatient or observation stays in 2012. So again, take Anne Arundel County. What we're saying is that there were 3,601 patients with chronic conditions. Patients who were seen 3 or more times in either inpatient or observation during calendar year 2012, and you can see that 555 of them had an asthma diagnosis, and that was 15% of the total number of unique patients. This next tab walks through a comparison of the high utilizers with patients with 5 or more chronic conditions. Again, what we have is Allegheny County, and there were 22,005 patients that had one of the 16 chronic conditions. Of those, there are not necessarily, I'm sorry, not of those. It's probably of those, I apologize. So then you have the high utilizers. Again, those are people with 3 or more inpatient stays, so there are 759 of those, or 3% of the unique patients. And the total charges and the average charges for those patients are here. Now, this is then contrasted with, we also looked at what are the patients with 5 or more chronic conditions. So out of the 22,000 in Allegheny County, there were 1,691 that had 5 or more chronic conditions. That's 80% of the population, and the total charges and average charges are listed here. Then for each county, we've presented a report that looks at the chronic, breaks down the people with each chronic condition by different payer groups. So for instance here, for Allegheny County, for asthma, we see that there were 243 patients seen who had fee-for-service Medicare. And that represented 4% of the total number of fee-for-service Medicare beneficiaries listed. Again, we have, restricted small sample sizes in these as well, and if you can scroll over on the bottom, you'll be able to see whichever county or counties that you're interested in viewing. And we can come back if there are questions, but let me move on to the other resources. Again, if you go back to our website, there are then 3 exhibits that are Tableau reports that are available on the web. These first 2 reports, the prevalence in Maryland counties and the conditions by county, are based upon data from the CMS Chronic Condition Data Warehouse. And I'll just click on one here. And so this first report shows you which chronic conditions are most prevalent in a county, so that you can understand how that prevalence differs from the state. So again, if we select, what you would do is select on a county up here. I'll pick on Montgomery County this time. When you select on one of the counties, you will then see the table down here and the pie chart update, and it'll provide for each of these chronic conditions, and these are slightly different chronic conditions than what we presented in the Excel sheet, but they match other reporting that Medicare does, and provides actually a little bit more granularity in some areas, for instance, breaking out Alzheimer's disease and dementia. What you see then is that for Alzheimer's disease in Montgomery County, 11.69% is the prevalence, and that is 69% higher than the prevalence, the statewide prevalence, which is listed somewhere, but I will find it. Interestingly, just so you can note, if you hover over the county, you'll get also some additional information. You'll get the average condition prevalence across all these conditions, as well as the number of beneficiaries in that county. And then if you hover on the pie chart, so let's say, again, I'm going to focus on asthma. I'm going to highlight asthma. Now you can see the pie chart where it is highlighting just asthma. If you hover over that, you can see that there are 3,803 people in Montgomery County that had asthma. Again, the prevalence rate then being 3.77%. As you're kind of looking at these, you end up clicking here, you click here, and if you come down here and hit reset, that'll take you back to the beginning. So if you've clicked on something you don't want to see, or if you're exploring and you want to restart, you can either hit reset or hit back. So the next exhibit is conditions by county, and I'll just open it here. This is very similar. It displays the exact same data, but rather than looking at it by county, we're now looking at it by condition. So over here, you can select, right now asthma is selected, but for instance, you could change to selecting diabetes, and the both the map and the bar chart below will update, and what it shows you is by county, what is the prevalence of diabetes, and then the red line indicates what the state prevalence is. So for instance, for Baltimore City, you can see that the prevalence is 31.41% for diabetes, and you can see that it is above the statewide prevalence of 28.58%. The last but not least, because this is based upon the HSCRC data, we have this final report that shows individuals who've had 3 or more inpatient discharges in fiscal year 2014. And what this provides is the 10 most common APR-DRGs among individuals who had 3 or more hospitalizations in 2014. And we present the data by payer type and by county. And again, I don't know how to zoom out, I apologize, but what you would do up here is if you would select what county you were interested in. So I'm going to go lower this time. Let's pick Prince George's County. So then the tables here will update, and what it shows you is that for the Medicare fee-for-service population, there were 1,066 discharges that had an APR-DRG of heart failure. And that actually represents 735 Medicare fee-for-service patients. Again, we have Medicare fee-for-service, managed care, we have Medicaid fee-for-service managed care, commercial and other payers, as well as self-pay and charity. So with that, what we're going to do is move on to seeing if there are questions or if anybody else here in the room has other things to add on the data we've presented. In order to ask questions, you can raise your hand, and we will let you talk, or if you type a question, we can read it, but we prefer to have some discussion.
We'll go ahead and start with some questions we received prior to the webinar. And I'll also point out that these questions, along with any that we receive from you through the webinar, will be posted to the FAQ, which is on the Regional Partnerships sites on the HSCRC website. The first question is, are the page, and these are not just limited to the data, but are broader questions for the overall funding opportunity. Are the page limitations for each section in the RFP strict or suggested guidelines? And may we submit relevant appendices? And the answer is that the page ranges specified in the RFP are suggestions, not strict requirements, and you are also welcome to submit appendices. However, we strongly encourage applicants to keep the overall application as concise as possible to facilitate a swift review process. The second question, when the hospital receives the increased rate option, the cash collected will be net write-offs of bad debt, charity, and contractual. Can we say that some of the $400,000 budget is for these write-offs? Otherwise, isn't the rate option hospital providing cash too? And I'll defer to the HSCRC staff to answer this question.
Yeah, so the idea is that the hospital receive the full $400,000, therefore the overhead will be applied on top of that so that the hospital will receive the full amount.
Thank you, Steve. The third question is, we asked CRISP for specific patient data today, and they said that they cannot provide this data based on the state requirements. When we get the grants, can we receive patient-level data among our hospitals if we have an agreement for each provider?
And the answer to that question is we have been requesting data from Medicare that's more patient-level, and we will probably not receive that until after the awards have been made, and we will make that available when we can for this purpose.
And we will have to, we're working with consultants to develop appropriate data sharing policies, and some of the data sharing will be limited, but we will be able to, similar to other projects that we've worked on with hospitals, to provide information under data use agreements. But we do have limitations on sharing, and we're making sure that we delve into those limitations at the current point in time. Ultimately, sharing agreements would have to be created in organizations, and permissions may need to be granted by patients in certain instances for some data sharing, and we're working on that we're beginning to work on that right now.
Thank you, Donna. The fourth and final question received prior to the webinar is, should an applicant provide letters of support from partner organizations mentioned in the proposal? And the answer is that you're welcome to submit letters of support. They're not a requirement. We would just encourage you, if you do submit letters of support, to only include those key partners, just so we can keep the applications concise and the length at a minimum. So now we'll open it up for questions that you may have through the webinar.
We have a question from Leslie Graham. Leslie, you're unmuted. Go ahead.
Hi, just on the first spreadsheet that you have, under unique patients column, is that where the patient lives or where they received service? Or you do it by county?
That's based upon where the patient lives. What my understanding is that it's rolled up. It was actually the last claim. If they had more than one within the calendar year 2012, we used that county to place them in.
Where they live.
I'm sorry? Yes, of where they live, correct.
Okay, but for example, in some areas where there's a lot of border crossing, that those numbers may reflect into another county for service, correct?
Correct. So a patient on the Eastern Shore might go to Johns Hopkins, but they're reflected in the Eastern Shore county that they came from. So okay. It's based on patient origin.
Very good. Thank you.
Our next question is from Tom Pianta. Tom, you're unmuted.
I just want to know if there were any additional technical specifications for the proposal. I think it's kind of been answered already in terms of length, but I was also thinking single space, double space, those kind of questions.
We're not providing any guidelines on spacing or formatting issues. We'll leave that up to you, other than the page suggestions that we provided in the RFP.
Thanks.
Our next question is from Margaret Fowler. Margaret, you're unmuted. Okay, Margaret's question was, can this data be broken down by race to show disparities?
I think the data could be broken down a number of ways. We have not broken it down in these workbooks by race. It could be broken down by race to show disparities. But we haven't done it at this point in time. If that's something that would be requested from a successful applicant, then we could do that going forward to help during the development process to be able to focus on areas where there are disparities. And I do think just based on having spent a lot of time looking at the chronic conditions, certainly the high numbers of chronic conditions are more prevalent in people with disparities. So I think there's a natural approach that occurs when we focus on chronic conditions, that we are actually focusing on a lot of health disparities also. But it is something that we could do going forward if requested for the planning process.
Alrighty, our next question is from Camille Bash. Camille, you're unmuted.
Yes, thank you for the webinar and for the Excel spreadsheet. I wanted to understand a little bit more, like somebody else, about the applications themselves. When you do some of the analysis, you might put a summary in the body of the document to stay to your 1 to 3 pages in different sections, but are we allowed to put appendices in that show more detail so we can keep the report itself short, or would you rather some of the appendice information be kept with the hospital and only given to you upon request?
It's really up to you. You're free to include appendices as you see fit. If you'd like to have some more detailed data in an appendice, I think that may be beneficial for you and for us in the review process. We're not issuing any specific guidelines in this area, so it's really up to your discretion.
All right, thank you.
Okay, our next question is from Jody Bitterman. Jody, you're unmuted. Jody, are you there? All right. I guess we'll move on to Catherine Barmer.
Yes.
Unmuted.
This is Zach and Catherine from Washington, Venice. And apologies, we're about 5 minutes late, so if we didn't go over this piece. But when we were looking at the data on the county level that you provided, now we're located down on sort of the southeast corner of Montgomery County, so some of our partners would also be in Prince George's, for instance. Do we have that data that's available? I know there was a question about the patient level data, but what about just the hospital level data? If we had other hospitals or clinics that were going to partner with us for the grant, how specific can we get on that?
In this process, we did not provide hospital-level data, but we can provide hospital-level data going forward for the planning process. So as folks are approaching the planning process, we can provide data by hospital.
And how do we get access to that? It would just be an email to you all?
Well, we're thinking about providing it after the application process is completed, not before the completion of the process. So we weren't planning to provide hospital-specific data until after the completion of the applications and the review process. So what we're doing right now is capturing data that folks might want. So far today we heard about data on race, and now we're hearing about data by hospital. So I think what we would do as we complete the process is to hear what all of the applicants want in terms of additional data and try to be as helpful as we can be in producing data that we can produce from our data sets. Thank you.
And then our question from Jody Bitterman was, I'm confused by high utilizers versus 5 or more chronic care reports. These are not mutually exclusive categories, correct?
Correct. So again, going to this report, they are not mutually exclusive, and so the high utilizers are those with 3 or more inpatient stays, and then the other group are the ones with 5 or more conditions. And I think we were trying to sort of contrast, again, looking at those people with high needs that are immediate, that are using our system, plus also looking at sort of that broader population of people with chronic conditions that aren't yet maybe high utilizers.
I think as one of the things that has come out of reviewing many care management initiatives is that sometimes they don't produce a return on investment because the intervention costs are higher than the savings. And so one of the things that you start to see is that the high utilizers, there's fewer of them and they cost more each. And so the savings per patient is going to be higher if you can target patients with higher cost and higher use. The savings per patient is going to be higher, and so those patients might warrant a higher intervention cost, like a case manager, case management service all in might cost $200 a month for high utilizer patients. On the other hand, the patients with 5 or more chronic conditions might be an ideal place to start with the primary care community-based providers to avoid some of the increasing avoiding the risk that might make them become a high utilizer. So of trying to mitigate some of the risk factors of reducing high blood pressure so we won't end up having strokes, for example. We saw on the high utilizers, for example, in Prince George's County, a lot of strokes and a lot of heart conditions. So if we can start attacking the chronic conditions in the primary care offices, then we can avoid some future high utilizing patients. So it's really kind of trying to focus on the two opportunities. One of developing plans to do care coordination and care management for the high utilizers, and 2, working with the community-based providers to avoid or to reduce the risk of people with multiple chronic conditions so they won't become a high utilizer. So that's what the purpose of kind of the contrasting table is, and you can see that the patients with 5 or more chronic conditions cost less each. There are more of them, but they could easily become a high utilizer if we don't do some interventions at this stage. So we really want the primary care community and the hospitals also focusing on developing community-based programs for them, particularly with the new Medicare chronic condition fee available to help provide the financing for that in primary care practices. That was probably a long answer to a short question.
Our next question is from Teja Rao. Teja, you're unmuted.
Thanks. Hi. I was wondering, when developing the sustainability plans that's listed, I think it's number 3, page 5 of the RFP, are hospitals encouraged or applicants encouraged or required to also propose how the partner organizations would be funded long term?
I would say that yes, if you can include that additional detail on sustainability for the partners, I think that would be very useful. You know, as much comprehensive information on sustainability as you can provide will certainly bolster the application, but it's not a requirement.
Thank you.
Our next question is from Sue Myers. Excuse me, we're actually still working on getting her audio up. So we'll go to Tracy Immel. Tracy, you're unmuted. You can go ahead. Tracy, are you there? Okay. Sue Myers' question was for the high utilizers, that includes 3 or more inpatient visits and observation days, or are the observation days not included?
So for the Excel sheet, the high utilizers are just defined as patients that had 3 or more inpatient and or observation encounters in 2012. That differs from the Tableau reports when they look at 3 or more inpatient discharges during that period. So again, the Excel sheet, it's inpatient and observation stays. The Tableau dashboard using the fiscal year 2014 data is just inpatient.
And then our next question was, are any of the patients in the 5 or more chronic condition group part of the high utilizer group and therefore not at risk?
I think most of the high utilizer patients will be included in the patients with 5 or more chronic conditions, because when you start looking at the high utilizers, most of them do have lots of chronic conditions. So, so I would say most likely the high utilizers are a subset of patients with 5 or more chronic conditions. So the high utilizers are at high risk. We would want the primary care doctors focusing on the high utilizers with us. When I say us, I mean the care management teams. So we would want primary care physicians focused on both high utilizers and patients with multiple chronic conditions. But for those patients with high utilization, we may have additional support resources like case managers helping to really manage the situation with the patient, because it has accelerated to a point where they need additional support, more than we could possibly expect the primary care office to provide. So that's how they relate to each other.
All right. Are there any other questions? Please go ahead and raise your hand.
Sue has her pin in her. You could unmute her to see if what's her question
Yes, go ahead. Sue, we see your audio got enabled. Do you have any follow-up questions, Sue Myers?
Yeah, it was just a request that when you add the information to the FAQs, if you could put a date next to it, it'll be easier to see what's new.
We can do that.
Okay.
Are there any more questions? Well, we want to thank everybody for their time and effort in working on these proposals, and we really appreciate it. And if you have any more questions as you work through the process, please feel free to submit them to the mailbox, and we'll get them answered. So again, thank you very much, and we appreciate all of your effort.